Spinal cord injury. Spinal cord injury SCI is a traumatic injury to the spinal cord that may vary from a mild cord concussion with transient numbness to immediate and complete tetraplegia. The most common sites are the cervical areas C5, C6 and C7 and the junction of the thoracic and lumbar vertebrae T12 and L1. Injury to the spinal cord may result in loss of function below the level of cord injury. Pathophysiology and etiology. Spinal cord injury may result from trauma, vascular disorders, infectious conditions, tumor and other insults. Second, the most common etiologies are motor vehicle accidents, falls, sports injuries and violence. Third, patients who have SCI, spinal cord injury, later in life are more likely to have incomplete cervical injuries. Older patients are more likely to have comorbidities such as hypertension, myocardial infarction and chronic obstructive pulmonary disease. Clinical manifestations. Clinical manifestations vary and depend on the location and severity of cord damage. In general, complete transection causes all loss of function below the level of the lesion, and incomplete cord damage results in partial loss of movement and sensation. Patients with injuries T1 and above have tetraplegia, formerly called quadriplegia, and injuries T2 and below have paraplegia. The neurologic level of injury is the lower neural level with normal sensation and movement. Classification is typically based on an impairment scale set forth. Injury is complete means no sensory or motor function, or if it is incomplete, some motor and some sensory function is there. Various syndromes, incomplete injuries may characterize a clinical presentation. Central cord syndrome, cervical injury with predominant weakness of the upper limbs, tetraplegia but able to ambulate. Brown-Séquard syndrome, BROWN, Brown-Séquard SEQUARD. Brown-Séquard syndrome, motor and proprioceptor, loss of ipsilateral side and pain and temperature loss on the contralateral side. Motor and proprioceptor loss of the ipsilateral side, pain and temperature loss on the contralateral side. Most recovery occurs within 6 months of injury. Patients with incomplete injuries have greater recovery than patients with complete injuries. Diagnostic evaluation, X-ray, spinal column include open mouth studies for adequate visualization of C1 and C2. Second one, MRI of spine to detect soft tissue injury, hemorrhage, edema, bony injury. Electrophysiologic monitoring to determine function of neural pathways. Urodynamic studies to measure both bladder and urethral pressure under fluoroscopy monitoring. If deep vein thrombosis or pulmonary emboli are suspected, an ultrasound of the lower extremity or ventilation perfusion scan is performed. Sixth one, heterotrophic ossification may be diagnosed in the inflammatory stages using ultrasound. Alkaline phosphatase and ESR are typically elevated. Seventh, nutritional status should be assessed using nutritional history, anthropometric measurements, pre-albumin and transferrin. Pre-albumin half-life 12 to 36 hours and transferrin half-life 6 to 10 days. Total lymphocyte count and creatinine height index are also used to establish nutritional risk. Management requires a multidisciplinary approach because of multiple systems involved and the psychosocial aspects of catastrophic injuries. Immediately after trauma, that is less than 1 hour, immobilization with rigid cervical collar, sandbags, and rigid spine board to transport from the field to acute care facility. Methylprednisolone, solumental IV given within 8 hours of injury to decrease the extent of injury. Contraindicated in systemic fungal infection, hypersensitivity, and pregnancy. Acute phase 1 to 24 hours. Maintenance of pulmonary and cardiovascular stability, intubation and mechanical ventilation if needed, vasopressors to maintain adequate perfusion, medical stabilization before spinal stabilization and decompression. Spinal cord immobilization, traction to reduce cervical spine injuries, kinetic turning, bed such as rotorest to immobilize patients with thoracic and lumbar injuries. Management of neurogenic bladder, insert Foley's catheter to drain bladder and monitor kidney perfusion. Fourth one, pressure ulcer prevention, pressure reduction mattresses or kinetic turning frame. When spine is stable, patient is turned every 2 hours and heels are suspended to avoid pressure. In subacute phase, within 1 week, stabilize vertebral column and ligamentous injuries through traction or surgical intervention. GM1 ganglioside sodium salt IV began with 72 hours after injury and continued for 18 to 32 days. H2 receptor blockers to prevent gastric irritation and hemorrhage. Early mobilization and passive exercise as soon as patient is surgically and medically stable. Hyperalimentation to retard negative nitrogen balance. Small doses of heparin to reduce risk of thrombophlebitis and pulmonary emboli within 72 hours of SCI, spinal cord injury, unless there is active bleeding, coagulopathy or head injury. Possible Venakava filter to prevent thromboembolism in patients who have failed anticoagulant prophylaxis or in whom anticoagulants are contraindicated. Neurogenic bowel program. In chronic phase, beyond 1 week, anticoagulants are continued until discharge with incomplete injuries, for 8 weeks with uncomplicated motor injury, and for 12 weeks or discharge from rehabilitation for complete motor injury and other complications. Management of complications may include treatment of infectious and with antibiotics, treatment of respiratory compromise with phrenic nerve pacing, mechanical ventilation and other methods. Pressure ulcer treatment, management of heterotrophic ossification with calcium chelators and anti-inflammatory agents. Drainage of syringomyelia, management of spasticity with oral or intrathecal antispasmodics, surgical procedure or spinal cord stimulation, and management of central neuropathic pain with anticonvulsants, minor studies, antidepressants, nerve block or surgical procedure. Rehabilitation includes medical and psychosocial support, physical therapy, urologic evaluation, occupational therapy and multiple other interventions to facilitate an increased level of function and community participation. Complications. Number 1, spinal shock lasting for few hours to a few weeks, noted by loss of reflex, motor, sensory and autonomic activity below the level of lesion. Number 2, respiratory arrest, pneumonia, atelectasis, mechanical ventilation often required with cervical injury. Number 3, cardiac arrest may result from initial trauma, worsening of initial injury from edema, concomitant injuries and other illnesses. Number 4, thromboembolic complications in 15% of patients. Number 5, infections, respiratory, urinary, pressure sore and sepsis. Number 6, autonomic dysreflexia, exaggerated autonomic response to stimuli below the level of the lesion in patients with lesions at or above T6 is a medical emergency and can result in dangerous elevation of blood pressure. 7th, autonomic dysfunction resulting in orthostatic hypotension, dysregulation and vasomotor abnormalities. Number 8, neurogenic bladder. Bladder storage pressure more than 35 to 40 centimeter may result in renal retardation. Paralytic ileus, ninth one, common in subacute and acute stage. Number 10, heterotrophic ossification, bony overgrowth that occurs below the level of injury and any time after spinal cord injury. Syringomyelia, cystic formation in the spinal cord, may occur any time after SCI. Syringomyelia, Syringomyelia. Syringomyelia. Depression occurs in 25% of men and 47% in the women with SCI. Pressure ulcers may occur in up to 35% of persons with SCI. 14th, spasticity may result in contractures. 15th, amenorrhea occurs in 60% of women with SCI, usually temporary. 16th, neuropathic pain occurs in 34 to 94% of patients with SCI. Nursing interventions, the points to include: attaining an adequate breathing pattern, promoting mobility, protecting skin integrity, promoting urinary elimination, promoting bowel activity, and preventing autonomic dysfunction and orthostatic hypotension, empowering the patient. Thank you.